Hi, my name is Dr. Seale. I'm a physical medicine and rehabilitation physician and also interventional pain management. I've been at Valley View for about a year and a half. I did my training in Texas before coming out here and really enjoy living out here and helping the people of this community. Welcome to Valley View University. I would like to thank everyone for joining today. I have a few housekeeping items to address before we get started. You can submit questions through the Q&A chat on the bottom of your screen. Your question could be answered live at the end of the presentation. We will try our best to answer your questions. We are unable to answer questions regarding personal health information. I'm going to talk to you today about back pain and all the different treatment modalities that we have to offer here at Valley View. So let's get started. All right. So breaking free from back pain, interventional pain management, and disclaimer, I have no conflicts of interest with any device company that I use, meaning nobody pays me additional money for using any of their devices. This content is only for informational purposes and should not be used in place of actual doctor's visit. A few objectives today that I would like to talk about. First, just some quick general anatomy just to help with some of the terms that we'll be using. Another one would be the MRI terms because we often read MRIs as patients and they use a lot of different words on there. So I wanted to help kind of describe what some of those words mean. Common types of back pain and then uncommon types of back and leg pain, common modalities, advanced modalities, key takeaway, and of course some questions at the end. So just to get started here with some common MRI terms. One of the ones that you'll see most often on an MRI will be spondylosis or arthropathy. Think arthritis, just like hips, knees, shoulders, you can get arthritis in the back. And that's often called spondylosis on your MRI. Stenosis, think of narrowing, so that could be in a couple of different parts of the spine. But you'll see stenosis in pretty much every MRI that you'll read. Neuroforamina, that is the nerve hole essentially. So where the nerve comes out of the back, neuro meaning nerve, foramina meaning hole, so nerve hole. Spinal canal, it's the center of the spine where all the nerves live before they exit your back. Disc bulge, herniation, extrusion, just think of degeneration of the disc, and the different terms just describe the disc slightly differently about how it actually protrudes into that spinal canal. Here's some general anatomy. So first starting with the spine here looking at it from the side, your spine has a few different parts. The ones that we most often talk about are the cervical, thoracic, and lumbar. Lumbar being the main discussion point for this video. That's your low back. Vertebral body is another term that we'll use a lot during this presentation. So that is the big bone here that a lot of the weight sits on to help support your spine. The disc is the little cushion in between the vertebral bodies. The nerve root is where the nerve actually comes out of the back through that neuroforamina or nerve hole. That's the nerve root there. And then the facet joint, again, a facet joint, your back has joints just like your hips, knees, shoulders. Your facet joint are those joints in your back, and that's labeled here. And that's what can get arthritis, where you see that term spondylosis or arthropathy thrown around. To talk about some of the different areas of pain. Now, your spinal column technically has three different components. You have the anterior, middle, and posterior column. For our presentation today, we are basically going to talk about the anterior column and the middle column being together, and then the posterior column being the other portion of the spine that we're going to talk about. The pain in the posterior column can be caused by a few different structures. One, it would be the ligaments that support the spine. You have a few different ones that run in different places to help, again, provide support to the spine. It can also be facet mediated. So again, facet is that small little joint. You can have pain coming from that. A radiculopathy, which is the term sciatica. If you hear that term, they're often actually referring to radiculopathy. Neurogenic claudication, that is again a different type of posterior column pain where the nerves are being pressed upon in the center of the spine or that spinal canal. And then post-laminectomy syndrome, again, we'll talk about that, which is basically you've had a surgery, but yet you still have back and leg pain. So just again to talk about the ligamentous injuries. So think of a sprained ankle. You can have a sprain in the ligaments of your back. Often in the cervical spine, if you're in a car accident and you have whiplash, it's often a ligamentous injury. So you would have some stiff low back, some muscle spasms, that you might get some muscle relaxers for, take some NSAIDs. It would typically improve by itself, usually about 10 to 14 days. And you don't necessarily need any kind of interventions as long as all the ligaments are intact. Facet mediated pain, this is a very, very common one for chronic low back pain. Again, your facet joints are those small little joints in the back that help you twist and turn. And so if you feel like you're trying to turn your body from side to side and you hear a popping or clicking and your back hurts pretty close to the middle, then it's likely coming from those facet joints, especially if you are looking up at the ceiling or you want to look up at the sky and you bend your back and start having pain right in the middle of the back. It's likely coming from those facet joints. It's typically arthritic. So again, it is a joint. You can get arthritis in it, just like hips, knees, shoulders. And again, presentation we discussed. A radiculopathy. So sciatica is often the term that's used out in the community for radiculopathy. I think it's a relatively poor term because it doesn't really tell you what the problem is. It more is a descriptor of the pain. So for example, if someone says, yeah, my sciatica is really acting up, well, really what that's saying is that you're having some nerve pain in the sciatic nerve, but the sciatic nerve is not the problem. The problem most often is coming from the back. The sciatic nerve is actually made up of those nerve roots that we talked about from L4 to S3. And so I provided a MRI here down in the bottom part of your screen that shows a large disc at looks like L4-5. And so that disc is likely pressing on a nerve root, which then causes that sciatica, but really it's a radiculopathy. It usually radiates into the buttock and the leg. It doesn't necessarily have to radiate all the way down the leg. It can even just be in the buttock, and that would still be a sciatica. The picture on the right side of the screen where you see that leg, those are dermatomes. So a dermatome describes where you might feel a pain from a specific nerve being pressed upon in the back. And again, it doesn't have to fit that distribution perfectly for that to be the problem. And most often it does not. Neurogenic claudication. This is often also described as spinal canal stenosis, or it's caused by spinal canal stenosis, and then you can get neurogenic claudication from that. That is pain that's in the low back, buttock, and legs. It's worse when you're standing and walking, and then improves rapidly once you sit down. Sometimes people say, yeah, when I stand for 5 to 10 minutes or walk for 5 to 10 minutes, my back and legs start feeling really tired. I maybe feel unstable, or I've even had some falls because of it. Again, my legs are jelly-like. And then one of the hallmarks, besides the pain going away rapidly when you go from standing to sitting, the other hallmark is the shopping cart sign. And so that is exactly what it sounds like. When you are going to the grocery store, you will see people leaning on a grocery cart. And they do that because when you lean forward, it opens the spinal canal where all those nerves live. And so a patient might tell me, if I'm walking out, going on a hike, again, I can walk for 5 to 10 minutes. or maybe a quarter of a mile. But when I go to the grocery store, I can do all my shopping. And we all know it takes longer than 5 to 10 minutes to go shopping. And they're very happy with how far they can walk in the grocery store. On these pictures, these are MRIs again of the lumbar spine. You can see starting from the bottom is L5 vertebral body, 4, and then 3. It gets a little bit tight, a little bit narrowed. Again, we call that stenosis. The two pictures to the side of that, the top picture is showing that central canal. And that's where you see all that white stuff in the middle. That's fluid that the nerves float around in and they're happy. Then you look at the picture on the bottom and you can't really see that fluid or that white in that central canal. All those nerves are being bundled up. And so that's called spinal canal stenosis. And then your symptoms would be neurogenic claudication. Post-laminectomy syndrome. So this is a problem for people who have had back surgery, but yet still have some back pain or maybe some leg pain, despite your MRI or any advanced imaging showing no stenosis or narrowing or compression of nerves or any other pathology, but yet my back and my legs still hurt. And this one's a little bit harder to treat for us because we don't have a target. Because exactly what I just said, the MRI or the CT don't show any pathology that would explain your symptoms. And so you can see here, this person has had a fusion from L3 to S1. They shouldn't really have any lower back or leg pain after having this fusion, especially if those nerves aren't being pressed upon. But yet, I'll still see people all the time with this kind of condition. One of the ways that I try to explain it to people is if you have a nerve that's pressed upon for years and years and years, and then you take that pressure off, it might not necessarily heal all the way. Another good example would be carpal tunnel. So people have carpal tunnel or that nerve being pressed upon in the wrist and start getting weakness or pain in the hand, and then they have carpal tunnel surgery. Well, they'll come and see me still and say, well, I still have tingling or pain in my fingers and my hand's still weak. I have trouble buttoning my shirt. Well, that nerve has been pressed upon for years and years, and it won't necessarily heal all the way, but it can help prevent it from getting even worse. Okay, so those are some more of the most common, like posterior column pain syndromes that we see. Now to talk about anterior column, again, this is pain coming from the discs that sit between the vertebral bodies or the vertebral bodies themselves. So discogenic pain. This type of presentation is usually somebody will come and see me and say, I lifted up this heavy box or this carton of water or what have you, and I felt a pop in my back, and this pain is radiating or shooting across my low back. It can even be something as simple as bending down quickly. So bending down to tie my shoe and ooh, pop in my back, pain in my back, maybe buttock. And it hurts like crazy. But the good thing about it is, again, it's typically time limited. So this MRI here on the side of the picture shows the vertebral bodies. You see L4 labeled there. Right below that is the disc, where it's all black. And then you have that white line in the back part of the disc. That is called an annular tear. And so that annular tear can be painful acutely. Now, again, it shouldn't be painful forever. Even if you get an MRI, let's say you get an MRI that week because you go to the ER, it could be because it's hurting so bad, you might see that annular tear. Well, if we get an MRI 3 years in the future, that annular tear might still be there. However, it should not be the pain generator. What it does mean, though, is that disc has started to degenerate. And that disc degenerating can then cause problems down the line. because now it's not working as it should. It's not providing a nice cushion to that vertebral body. And that leads to what we call vertebrogenic pain. Again, so vertebrogenic pain is pain coming from the vertebral bodies themselves. This is pain just in the low back with no radiation of pain down the legs. Okay, so if you have any radiation of pain down the legs, you may still have a component of vertebrogenic pain. However, that is not causing the shooting pain down the legs. Now, this type of pain is often described to me from the patient very quickly. I'll walk into the room and the patient will be standing because every time they sit down, that back starts to really ache for them or it's intolerable pain. Another way to think about this one is if you go for a long car ride, let's say you're going up to Denver, you say, "Oh, I got to get out of the car every 30 minutes or an hour because my back is just killing me." And then when I do get out of the car, I have to very slowly kind of inch my way up to be able to stand up straight. Or if I lean forward to tie my shoes, my back starts hurting me very quickly. And these MRIs over here show what we call modic changes. So you can see in that vertebral body that we have a nice little blue circle there showing us where the problem is. On the picture on the left, the vertebral body is dark. It's not nice and gray and uniform like that vertebral body right above it. And that's a sign that you may have vertebrogenic low back pain. Then we look at the picture next to it, which is again, it's the same MRI of the same location of this particular patient, and it shows these little white kind of quarter circles in that vertebral body. This is called a modic type 1 change, which is inflammation of that vertebral body because that disc that sits between the vertebral bodies has started to degenerate. So, much like your knee, if your cartilage in your knee degenerates, you start getting arthritis and inflammation of the two bones in the leg that support the knee. That can happen in the same manner in the vertebral bodies. We just call it a different word. Some other types of vertebrogenic pain are compression fractures. So a compression fracture is acute pain, and that would be just in the center of your spine, maybe radiating out to the sides, and you would typically be able to remember an activity that caused it. Now, it doesn't have to be a big traumatic injury. It can be, I was bending over to tie my shoe, felt a lot of pain in my back, and it will not go away, and it's unbearable. If you get an X-ray, you might see that these vertebral bodies have collapsed. And it could just be one or it could be multiple. There's no radicular or nerve component to this type of pain. It is only of the vertebral body. This MRI that you're looking at here shows the thoracic spine. It has two arrows. If you look at the vertebral body above the top arrow, that vertebral body is nice and square. So that's a nice healthy one. Then you look at the top arrow pointing to the vertebral body, and it looks like it has collapsed. It's still dark, meaning it looks very similar to the healthy vertebral body above it. What that means is that vertebral body has had a compression fracture. However, it has reossified or has become hard again, and there's no swelling inside that vertebral body. Then you look at the arrow with the long tail or that bottom arrow, and you see that vertebral body again has collapsed. It's not a nice square, and it's white on MRI. That white again shows that it's an active compression fracture. Now, I say this because if you get an MRI on someone who has had a compression fracture, let's say 5 to 10 years ago, and they say, well, look, you have a fracture of your back. Well, you may, But that shouldn't be painful because that bone has healed again. It has become hard again. Now, if you get an MRI and you see white in that vertebral body, then that's a sign that, oh yes, that can definitely be a pain generator. And we have some treatments for that. For chronic ones, there's no really treatments because that vertebral body should not be causing you pain. It can cause pain in other ways because it changes the forces through your spine. All right, so those are some brief overviews of some common and less common pains that we see in the spine center. To talk about a few common modalities, so physical therapy, that's really the mainstay of chronic and really acute low back pain. The idea behind it is to strengthen the muscles of the back and the abdomen, so the muscles that support the spine. That has the best evidence for treating chronic low back pain, more so than anything that I can do. However, it doesn't always work for everybody, and you need additional treatments. And that's when you start talking about medications. So, common medications, acetaminophen or Tylenol, NSAIDs such as ibuprofen, meloxicam, naproxen, and muscle relaxers. Oftentimes, people will say that acetaminophen or Tylenol doesn't quite work for me. Well, maybe we need to talk about how you're taking it. Same thing with ibuprofen, meloxicam, and naproxen. Just because one NSAID doesn't help you doesn't mean none of them will. And so it's often worth trying other types of NSAIDs. Muscle relaxers, quite honestly, they're not my favorite types of medications because they often make people tired. Some people like that though, because they say, Doc, I can't fall asleep at night. I feel like my back is spasming. Okay, great. Let's try a muscle relaxer and hopefully that at least help you sleep. To talk about procedures that we can offer for and that are common, we have the facet joint procedures first. So the facet joint again is that small little joint in the back that helps you bend and twist and move around, extend your back, flex your back. That can become arthritic. Tie that back into those MRI terms. That's when you see spondylosis. These facet procedures are what you use to treat that. So this first picture on the left just shows a facet injection that's injecting some steroid and a little bit of numbing medication within the joint to try to decrease any kind of inflammation inside that joint. Again, just like you would get for your knee. You would often try a steroid injection to see if that could help you out in your knee. You can do the same thing for the back. This picture on the right, these are showing some specialized needles that have an active tip or a tip of that needle that can heat up to 80 degrees Celsius and it actually ablates, burns, or cauterizes, whatever term you like to use, a small nerve that can send those pain signals from the joint to your brain. And so if you can burn that nerve, then it can't send those pain signals to the brain. The facet injections can last usually between 3 to 6 months. The radiofrequency ablation is what we call this other procedure with these special needles. Typically lasts between 6 and 9 months. The next common modality that we have for back and leg pain are epidurals. These two pictures show different types of epidurals. The picture on the left shows the needle coming in from the side of the spine, going in that neuroforamina, again, that nerve hole. That black stuff that you see is contrast, and that shows us that we are in a safe spot, that we are where we want to be, right around that nerve that's being pressed upon. We can't see the nerve on this x-ray, but we know that's where it is because of the MRI. And then we know we are where we want to be because of that contrast. So again, that's called a transforaminal epidural. The picture on the right shows an interlaminar epidural. So that needle is coming in the middle of the spine. Again, all this black stuff here is the contrast that we can see on an x-ray to show that we are in a safe spot. Now, what are epidurals used for? Those are used for those other terms that I discussed as a radiculopathy or that central canal stenosis with neurogenic claudication. So again, if you come into the office saying, I have sciatica, well, that's from a radiculopathy, and an epidural is often the mainstay treatment for that before you would talk about anything more invasive. Some advanced modalities that we have for back pain include these four, which is kyphoplasty, spinal cord stimulation, peripheral nerve stimulation, and Intracept. So to start with kyphoplasty, a kyphoplasty is used for those vertebral body compression fractures that we talked about earlier. The compression fractures can come from osteoporosis, maybe you have cancer or trauma. I fell off a ladder, had a lot of pain in the middle of my back. The nice thing about a kyphoplasty is it's not technically a true surgery, meaning I don't really have to cut the skin or do any kind of suturing or anything like that. I use a special needle essentially to get access to the vertebral body. So if we look at this top left picture, that's showing that needle coming inside that vertebral body. I then blow up a balloon to create a cavity and also help see if we can get some height back on that vertebral body. Once I have that cavity, I fill it with cement. Now, kyphoplasties are great for people with acute severe pain because it stabilizes the bone inside that vertebral body. Think of it as a cast. So if I break my arm bone, I get a cast. That cast prevents me from moving my arm and irritating that bone. And so my pain is better because I can't move that bone. It also helps it heal faster. That's essentially what a kyphoplasty is. It's an internal cast for that vertebral body. Again, the good thing about this is it's not a true surgery. It usually takes around an hour or so, and people often feel better the same day or maybe the following day. It would not be uncommon to have some post-procedural discomfort. However, that severe pain that you're experiencing before the kyphoplasty should be improved rather quickly. The next modality that I use is called spinal cord stimulation. Spinal cord stimulation can be used for a variety of painful conditions, all the way from that post-laminectomy syndrome that we talked about to diabetic neuropathy of the legs, chemo-induced neuropathy of the legs, and even non-surgical low back pain. Or if you have severe scoliosis, then that surgery would be a massive surgery and you really don't want to do that. Well, maybe we try spinal cord stimulation first for you. The good thing about spinal cord stimulation is you get to try it before you buy it. So you put the leads in the epidural space, which is what this picture on the far right is showing, as this little wire sitting on top of this yellow structure. The yellow structure is the spinal cord, and that gray structure, that's the wire. Now, those leads stay in place for around a week, and you work with the device rep during that week to try to decrease your pain. At that week mark, you'll come back and see me. We'll take those leads out right here in clinic. They slide right out of your back, no problem at all. Shouldn't really cause any kind of pain or anything like that. We ask you, how'd it go? If you say, Doc, are you sure you have to take those leads out of me? That makes me really excited because I know for a fact that you really enjoyed it and a permanent stimulator can be very helpful for you. Technically, anything over 50% relief for that week is considered a successful trial. Again, I like people to say, are we sure we have to take those leads out today? Or, yeah, it helped me 60 to 90%, something like that. That makes me really excited for you. And I think it gives you a higher chance of having a successful permanent. Now, with the permanent, everything is underneath the skin. So there is nothing hanging out of your body. This little gray oval circle is the generator. Again, that would be underneath the skin. Usually try to put it below the hip bone here. And then that wire is coming off the generator and then going again into that epidural space. The battery has to be changed depending on the type of battery that you use. It can last anywhere between 3 and 12 years. And there are some nuances there that we could discuss if we ever get to that point with you. Next would be peripheral nerve stimulation. So peripheral nerve stimulation is doing exactly that. You're stimulating the nerves outside of the spine. This has its pros and cons as well. It's a temporary device, meaning you leave it in for 2 months and then take it out. Well, that's nice because again, it's not permanent. However, the cons is that you have to wear that device for those 2 months. So these pictures here show some of the more common areas that you can use peripheral nerve stimulation. Neck, shoulder, back, and knee, those are definitely the most 4 common. I have been using it for the shoulder and a few patients for the back. Everybody who has had it for the shoulder so far has really enjoyed it. And that's what actually it was first invented for, was to treat chronic shoulder pain for patients who aren't surgical candidates. The other good things about this procedure are there's no need to stop any medications. So if you're on blood thinners like warfarin or apixaban or Eliquis, rivaroxaban, aspirin, you don't have to stop it to have this procedure done. So that decreases the risks of a blood clot. And then the duration of pain relief, again, it's described as being helpful for that 60 days. Now, if you read about it online, it might read a year to a year and a half. Quite honestly, I'll be happy if people get a similar amount of relief than radiofrequency ablation, where you burn that nerve. So 6, 9 months, maybe a year. I'll be quite happy with those people with that result. Another good thing about it is that you're not destroying any of your native tissue. So with radiofrequency, you burn that little nerve that sends that pain signal from the joint. With this, you stimulate it. So you don't destroy that nerve and you don't have to actually even touch that nerve. You just have to get close enough to it to stimulate it. Next would be called Intracept, also known as basovertebral nerve ablation. So this is for axial low back pain, meaning pain in the back that's not radiating down the legs, that you've had for more than 6 months and has failed conservative therapy, such as physical therapy and medications. With this procedure, what you're doing is ablating, cauterizing, burning, again, whichever term you'd like to use, a small nerve that's inside the bone of the back called the vertebral body. The way you access that vertebral body is the same as a kyphoplasty. The cool thing about this procedure is that it has 5-year data. And so in the pain world, most modalities that we have are rather temporary, 3, 6, 9, maybe 12 months. Well, with Intracept, it has 5-year data. And that's only because that's when the study stopped. They have since started following those people who were in the initial trial, and will hopefully be releasing that data in the next couple of years. But it does seem as though that nerve does not grow back like it does for the facet joint or the radiofrequency ablation for the joints of the back. Again, this is not a true surgery. There's no incisions or suturing that's needed. All right, a couple of key takeaways from this talk. One thing I want to really describe is that we talked about a lot of different types of pain pathology. Well, us being humans, we don't fit textbooks. We often have multiple pain generators. So for example, if someone has a radiculopathy or sciatica, it's often caused by degeneration of the disc, facet hypertrophy or arthritis, meaning the small joint of the back, and ligamentous hypertrophy or thickening. So if we treat the radiculopathy, well, my maybe my shooting pain down my leg feels better, but my back still hurts. Well, all right, let's treat the facet joint. Or maybe you have some motor changes or some pain coming from that vertebral body because that disc has collapsed and now you have pressure on the vertebral body. Well, let's treat that now. Next would be not every procedure is right for you. So one thing that I hear relatively commonly is, my relative had radiofrequency ablation and it really, really helped them. Well, maybe you have shooting pain down the leg. Radiofrequency of the back isn't going to help that at all because it's not treating that pathology. Sometimes it's trial and error, unfortunately. We try our best to diagnose the pain generator, but again, we are not textbooks as humans. And so sometimes we try things, and if it works, great. If it doesn't, well, all right, maybe that's not the pain generator. Let's focus on something else. Another one is MRIs often sound more serious than they actually are. Um, One of the most common things that I hear in the office is that, well, doc, I have bulging discs all throughout my spine. Okay, that's not necessarily a problem or your pain generator at this time, because a bulging disc in and of itself isn't actually painful, unless, again, it's an acute annular tear or it's pressing on a nerve or has degenerated so much that now you have pressure on that vertebral body, and that's actually the pain generator. So be careful when you see your MRI and it has a paragraph of all the different things going on in your back. The radiologist has to read it like that because they have to list all the different problems that they can see. Another one is just because I'm in the spine center, and it doesn't mean that I only treat the spine. I also treat problems in the periphery, just including something like CRPS, which is complex regional pain syndrome, post-herpetic neuralgia, meaning pain after shingles, different types of peripheral nerve pains, such as diabetic peripheral neuropathy, chemo-induced peripheral neuropathy, or another one again that I've been doing here lately is non-operative shoulder pain using that Sprint system. All right, so that's the end of the formal presentation, and now we're going to open it up for questions.
All right.
Let's switch that.
Yeah. Perfect. Okay. So first question is, can you explain what interventional pain management is?
Yes, so interventional pain management is using these common modalities and the less common modalities that we discussed throughout this presentation. So again, using things like epidurals or radiofrequency ablation for the joints of the back, spinal cord stimulation, sprint peripheral nerve stimulation. Those are all interventions. Pain management in general is also using, medications, physical therapy as a team, and other procedure or other interventions that don't necessarily involve needles through the skin.
All right. Is SCS implant MRI compliant?
Yes, so the newer systems for spinal cord stimulation are what we call MRI conditional. So if and when you have a spinal cord stimulator implanted, you'll receive a card that you can show the facility that you're having your MRI, and they can make the small adjustments that they need to make with their MRI machine. Now, if you have an older unit with older leads, those are not always MRI conditional, but the newer ones are.
Do spinal cord stimulators only target one lumbar level, or does it help at multiple levels?
Multiple levels, yes. So spinal cord stimulation is more of a less precise way to treat back and leg pain. So what we would do during the trial is we would do an epidural. So put a needle into the epidural space, slide that wire through that needle. We would then turn it on, and you would feel buzzing or tingling. and we would ask you, is this covering your painful area? You say yes or no. If you say no, then we adjust where those wires are sitting in the epidural space. If you say yes, okay, great. We leave that in place for that week.
What is laminectomy with nerve root decompression?
Yeah, so a laminectomy is removing a small portion of the bone on the vertebrae. So if you think of your spinal canal as a room in your house, well, if you take the roof off of your house, what you're doing on your back is doing a laminectomy. So you're taking that bone off the bone off the vertebrae and opening up the space where those nerves are trying to exit the back. And that's the decompression part of it.
Which interventions can be successful following unsuccessful fusion?
So that would be primarily spinal cord stimulation if you have leg components. So if you have just a back component of pain, then it is possible that you are having other pathology above or below the fused levels. And so we would need to evaluate to see if your MRI shows any new pathology that could explain the pain. If not, then we start talking about spinal cord stimulation. If we do, then we would use those other appropriate treatments to treat that pathology.
What are the cons in kyphoplasty?
So the cons with the kyphoplasty are basically the risks. So with a kyphoplasty, the risks are going inside of that central canal where all those nerves live. That would be a horrible, horrible outcome because we could damage those nerves. Now, we use x-ray machines to guide our needle down into that vertebral body, and we take a ton of pictures to make sure that we stay in a safe spot when we are doing that kyphoplasty. Additionally, it has been described that when you are putting the cement inside of the bone, sometimes it can exit the bone and go where you don't want it to go, such as that spinal canal or even into a blood vessel. Now, that cement has contrast in it that we can watch where that cement goes. So if it starts looking like it is wanting to exit that vertebral body, we stop. The great thing about a kyphoplasty is the data shows even if you get a little bit of cement inside that bone, it helps with the pain. You don't have to fill it up completely.
Is there any intervention or option for residual or ongoing numbness or nerve damage years after microdiscectomy or laminectomy?
So the question is there any treatment for ongoing numbness or tingling after a discectomy? Numbness, no. If it's painful numbness, which sounds counterintuitive, but it does exist, then yes. But if it's numb, not necessarily.
Can SCS go to multiple locations?
I think can SES go to multiple locations? I might need a clarifying follow up on that one. If you mean can it treat various parts of the body, then yes. We can treat the legs, back, technically the arms. It is off label for cervical spine, but you can use it, and I have used it for those. Um, I think if that's the question, then yes.
What is the recovery time for SCS?
Okay. For the trial, it's pretty much immediate. You might have a little bit of post-procedural discomfort for a day or two, and then that should go away. As far as the permanent implant goes, we often tell people to try to limit bending, lifting, and twisting for 6 to 8 weeks because we want time for those spinal cord stimulator leads to scar into place. So then when you start doing those activities that you want to do, they don't move and then not help you out. Any kind of pain from the small little incisions that I have to make should really be improved by the first week or 2 weeks.
How common is pain in the area of the SCS implanted device?
It's about 5% of patients get what we call pocket pain. There are some tricks that the representative can do to help treat that pocket pain, meaning they can kind of turn that generator into a lead and send a little electrical signal out of the generator itself. Worst comes to worst, if it is totally intolerable, unfortunately, I have seen people have it explanted or taken out if that pocket pain is too bad. I have also seen people move the generator, so try to put it in a different spot because maybe it's helping their chronic pain, but yet they're having this pocket pain that they can't stand. Well, let's move it to a different spot, see if that helps you out.
If I call to make an appointment with your clinic and tell them I have low back pain, who will I be seeing after making the appointment? Would it be a pain management provider, a surgeon, a PA?
So if you called and were just saying you have low back pain, you could get referred to either myself, Dr. Hahn, or one of our three surgical PAs. You would not likely be seeing Dr. Tuarte, our spine surgeon. If you specifically ask for either myself or Dr. Hahn, then you should see one of us.
What are your thoughts on artificial disc replacement? Is it an option for multi-level lumbar disc degeneration?
I think that's a great question for Dr. Tuarte, our spine surgeon, as I do not do those procedures.
So to clarify that earlier question, can SCS leads go to multiple locations of the back simultaneously?
Yes. So the question about can the leads be placed at different spots? Yes, they can be. Now, typically, if you, let's say you have neck and arm pain as well as back and leg pain, typically you would do one area first and then the other area.
What is your experience with the Intercept procedure?
So with Intercept, with my own personal experiences, we have not started doing those currently at Valley View. It has been the procedure I've been wanting to add for the last couple of months. We do have approval to start getting authorization for people in the end of this month, and hopefully we'll start scheduling patients in May. Now, again, my own personal experiences, I have not done the actual procedure on an actual patient, but I do kyphoplasties, which is again the exact same approach. There's really nothing different except for what goes inside the vertebral body.
Where do you see patients?
We see patients, I personally see patients at Valley View Main Hospital as well as Willits. So Willits, I'm there every Friday, and then Valley View the other days of the week. The Spine Center in general has offices in Eagle. We're starting to go to Silt, and then of course Willits and Valley View, Maine.
How can I schedule an appointment with you?
So again, if you wanted to see me personally, I would recommend that you call the Spine Center at 970-384-8060 and then ask to see me.
That is all the questions that we have.
All right. Thank you very much for coming today and being a part of our webinar. Our team would love to hear your feedback on today's presentation. If you have time to fill out a quick survey, it will appear right after the webinar has ended. You will also receive an email with the recording of the webinar within the next 24 hours. The next Valley View University is on Wednesday, May 7th at 6 p.m. with Valley Ortho's Dr. Susan Inscore and physical therapist Jessica Gagliani. They will be presenting on optimizing bone health and reducing fractures. Hey, that lines up very well with our kyphoplasties. Thank you all again for joining today. Have a great rest of your day.